Welcome back, Health Impact audience. We have a very popular topic that we've covered a few times this year that is back for a redux, and that is the idea of how accessible the virtual care that we seem to be delivering more and more of over the last couple of years, especially, is becoming more important or less important in certain areas. So what we wanted to do was to talk both from a healthcare delivery angle, and we've got Dr. Schwann to help us with that. We've got Josh from Scan Health Plan to help us from the payer and the plan angle. And Jan here is going to help us understand what does accessibility and access have to do with each other, and how does that work with virtual care. So one thing I wanted to start with is the idea that, for example, we've got elderly patients, we've got rural patients, those with disabilities, language barriers, et cetera, coming in because we've done a really good job of opening access to patients. So those patients that had to drive for many, many hours can now just come on to video. But we've made the assumption that, oh, once we've made video available or audio available, that means access. And of course, that's not true, because access is not the same as accessibility. So we're going to talk a little bit about that, as to say, where is virtual care today? What's good? What's working? What's not working? But really, what does access actually mean, both from a provider perspective as well as a payer perspective? And then where does the tech fit in with respect to accessibility? So with that, Jan, I'd love to have you introduce yourself. We'll then go to Lee and then Josh, and then I'll pose the first question to us.
Thank you. I'm Jan Smith-Reed. I'm working for T-Base Communications, and what we do is focus clearly on making communications accessible. Spent my whole life in healthcare, whether on the operations side or sales and marketing and account management side. So, here we are moving to a digital world. Healthcare is certainly still in the big print business, and I think we all understand that. But I'm really excited to talk about the technology, how that really impacts accessibility, but then how there's so many means of communications with members that we still need to keep in mind and make those accessible as well.
Yeah, fantastic. Welcome. Lee, your intro.
Hi, Dr. Lee Schwam. I'm the Vice President for Virtual Care at the Mass General Brigham Health System, formerly Partners Healthcare. I'm a practicing stroke neurologist in my spare time, and I've been in the field of digital health for about 20 years. And I just want to tee off something that Jan said, which is, we have so many implicit assumptions, and we don't recognize, I love that, we're still in big print. So our front door is inhospitable to lots of people, and our digital front door is inhospitable to a different group of people. We're never going to have a perfect front door. We just have to have mitigation strategies to make sure that our doors are open in one way or another to meet as many patients' needs as possible.
Those are such great insights. Josh, if you could do a quick intro, and then I'll jump back to ask a quick question from Lee about that, what he just posed.
Sure, I love those insights, Rohit. I'm Josh Good. I'm CIO of Scan Group and Health Plan. We're a Medicare Advantage health plan based in Southern California. We operate in 3 states, Arizona, Nevada, and obviously California. Obviously, as a Medicare Advantage plan serving the senior population. So happy to be here today and talk about their perspective on telehealth and virtual care.
Awesome. So Lee, one of the reasons I wanted to start with you is you guys have been doing this for decades, right? Not just 2 years post-COVID. So given the past couple of decades that you've seen at now you're Brigham's, so tell us a little bit about what the current landscape of virtual is. Mostly we see things working, but if you can hone really on where are we not doing things maybe as well as we could be in terms of virtual care, and what's not working would probably be a good place to start. Then I'll have Josh and Jan jump in on what they see in their landscape as well.
Great. Well, thanks so much, Shahid. So a lot of our early work really focused on institutional consultations, keeping a stroke patient in an emergency room in New Hampshire local by providing expert advice, initiating care, but there was always a chaperoned interaction. And then we began to experiment with virtual visits pre-pandemic. It was pretty much a coalition of the willing. It was providers who were interested in piloting this. It was their patients who were really eager to do it. And we found, it was mostly wealthier patients who lived far from the hospital, who preferred to come virtually as opposed to the 2.5 hour, round trip drive and all the inconveniences. When COVID hit, it was no longer virtual versus in person, right? It was virtual versus nothing. So the doors opened pretty wide. We had massive adoption in our provider group, almost 10,000 providers. Of all the people who ended up doing a visit that year, 90+% did it in the first 6 weeks. So, right, it was just this, like, everyone's doing it now, and all the patients were being scheduled for virtual, and a lot of them really struggled. And so we saw right away, like everyone else, that if you didn't speak English, if you were older, and if you had other social determinants of health, you were much more likely to struggle. And we used audio only, good old telephone, as a way to bridge care for a lot of those patients. Now, in behavioral health, that might be fine. But in other conditions, not having the video is a real limitation. So one of the risks, I would say, one of the early failures for all of us was we were not able to address the health needs of some of our most vulnerable patients. Now, those patients, ironically, had always been able to come to our front door. They just needed to, get on the bus and be able to show a piece of paper at the front desk of where they needed to go. They didn't even need to speak English to make it to our office. And then hopefully an interpreter was there to help them navigate the visit if they didn't speak English. So I think we struggled there. We struggled getting interpreters into our video-enabled interactions initially. We didn't have a good conduit to bring our interpreter vendors into that. We struggled with children, particularly those who require a portal account, but are in that middle age group where they're minors, but their parents can no longer be present if they, it's complicated, but there's this middle age group where the regulations get really thorny. And I think that we really still don't have a great handle on our patients with visual and cognitive deficits. I think for the hearing impaired, we do have the ability to have ASL interpreters join. But for the visually impaired and for those with cognitive impairment, we're really relying on a chaperone, family member, loved one, somebody who's going to help them navigate that visit. And, quite frankly, we've always relied on patients to bring their own helpers to these visits anyway, right? We encourage patients to bring people with them to visits. It makes them more effective as patients. But we've now put another burden on the backs of the quote unquote support system for the patient. Now they're not just emotional support, they have to be cognitive support, tech support, and that can be really challenging. So I would say that those are our early struggles. We've made a big commitment to translating our portal into multiple languages. We've made a big commitment to creating sort of digital access coordinators who are stationed in some of our primary care clinics in areas where patients have been suffering and struggling to get onto our digital platforms. Those are helping, but those are still, small numbers. And so we just got a big grant from one of our local foundations to study better ways to bridge the digital divide. And we're hoping to do that with digital tools, because we know that from a labor perspective, we can't afford a one-on-one human interaction. And so we learned that chat, interactive texting, interactive voice, there are other vehicles besides print or plain old telephone that even our older patients or patients who don't speak English as their primary language are much more comfortable leveraging. So let me pause there and turn it back to you.
No, that's a great landscape overview. And before bringing Josh in on the payer and the plan side, what do you think, Lee, is the outlook? Let's say the short-term outlook, next 18 to 24 months. If you look back at the last 18 months, you saw a massive spike, a reasonable drop, because we couldn't sustain that massive spike anyway. Yeah. So a reasonable drop. But do you see it further leveling now, or is it now continuing to fall as far as utilization through telemedicine and remote patient monitoring?
Yeah, so I think what we're seeing is differentiation. Our behavioral health specialists are 90% plus virtual. They're never going back to the office on a regular basis. I mean, there will still be office-based providers, but the bulk of that is going, and we have payment parity for behavioral health indefinitely now. So that's, that's sort of mainline. I think some specialties are going back toward mostly in-person, also to address a lot of pent-up demand for in-person services. And I think we're seeing patients are beginning to express preferences, or we're beginning to target patients to one technology versus another. But I'm worried that it's not thoughtful and intentional. It's just path of least resistance. And I don't want us to snap back to, well, just have them come in, right? We don't want that. We also don't want, hey, I don't like to work in the office on Fridays, so I'm all virtual on Fridays. Don't you dare book me an in-person patient. I think we have to really embrace both a moral imperative as well as a business reality. If we stop offering this service, our competitors who offer it as a digital first alternative are going to attract a lot of patients away from us. So I don't think we have a choice. What we have to do is address that plus the moral imperative that Jan was alluding to at the very beginning, which is we have to make sure our doors are open for everybody. And it may be one door for one person, it may be a digital door for Jan and an in-person door for Josh, but we have a moral imperative that as an academic health system, we can't shirk.
Great. And Josh, bringing you in, let's bring you in on a hard question, which is Lee mentioned payment parity. Can you describe what that means for the audience? And then say, has payment parity or payments in general led to what you believe to be more or less use of telemedicine during the last 18 months? And then I'd love for you to start with that answer after answering, what is payment parity and what do you guys see about that? What do you see as the next 18 months as far as utilization is concerned?
Sure. Yeah, and it's amazing listening to Lee talk there and just the experiences. I mean, on the payer and the provider side, very, very similar, experiences across the board or what. But payment, integrity. I mean, looking at that, I mean, the reimbursements, I think, definitely over the last 18 months has, increased the access, from a, telehealth virtual care perspective. And I do see that continuing. I mean, I don't see us, going back. I mean, Lee made the statement about, our competitors would, really move into this space if we were to pull back and not offer, these type of services. Yeah, I don't see us going back. And, what we've been focused on at SCAN is how do we enable, our members, our patients, how do we enable them to be able to access these services? We like to make sure we're offering a wide variety of services for, our members. Digital is not for everyone. There definitely is a digital divide out there, but we want to make sure we have the right touch, the right channels, the right services, for our members. And that's where, we feel we really have to have a broad suite of offering of services that will support all of our different members across the board. But as I look out over the next 18 months, continue to see the adoption accelerate. We're working with our members, trying to get them more comfortable, trying to bring down the barriers of that digital divide. One of the stories I like to talk about when I talk on this subject is, when the pandemic hit, one of the things we did at SCAN is we launched a member technology support line. We're looking to support our members where, what we had seen with the pandemic, our members were really thrust into this digital world. If you wanted to maintain care, you had to be digitally savvy. I mean, there was not an option, to go visit your clinician in person. And it's been very successful. So, I was a little nervous. Our first call was a 92-year-old member. It took 45 minutes, but he needed an email address. He had never sent an email before and had to register on a patient portal to get access to the telehealth site. And we walked him through the process of setting up an email address and, walked him through what that visit would be like. The visit, is, the experience is very different. It's, not the same as an in-person experience, but we continue to educate our members and look to see adoption continue to increase over the next 18 months.
Got it. And so, Josh, as you think about the struggles that you had early on, were those mainly struggles on the patient side and the providers got their education and came up pretty quickly? Or was the problem on both sides that the providers weren't ready and the patients sometimes the patients weren't ready and the providers were? Is that still going on, that dichotomy?
A little bit. I would say it's more on the patient side nowadays. I mean, so definitely at the start of the pandemic, it was on both sides. And obviously, each patient is different, but we saw a pretty large digital divide. I mean, obviously, we're working with the senior population, and there were struggles, getting access to care, and just the basic things of signing up for a patient portal. Things like that can be challenging. I mean, they seem simple and easy, but they can present challenges to those that are not as digitally, savvy or as advanced or what. And I think on the provider, the health system, health plan side, we've gotten better, with our, telehealth, our virtual care offerings or what. One of the things we saw, at the onset of the pandemic, a lot of these telehealth solutions were behind patient portals. So, as I talked about, you had to go register, you had to have email, which, for like the example I gave, some individuals don't have email and they're not used to using email. And I think we've gotten better as a health system where we've made access much easier. Now you get a text reminder and click the link and you're right into your, virtual visit or what. So, we've gotten better as a health system. We've brought down some of those barriers to the access and made it a little bit easier for those that are not as digitally savvy.
Mm-hmm. And if you let me put some words in your mouth, I think what you're saying is that you're predicting at least leveling and staying at level or going up as far as remote patient monitoring, virtual care, et cetera. Is that about right? So you don't think it's going to be coming down?
Yeah, I don't see it coming down. I think we're going to go up. Obviously it's not going to be like it was at the onset of the pandemic where, a steep climb, but I think we're going to see a steady climb as we get better and we make it easier and the technology gets better and it makes it easier to be able to service our patients, remotely.
Got it. And so, Jan, when you look at the technology getting better, as Josh just put it, there's a lot of problems. And you heard Lee and Josh to talk about just data, like getting an email account was a problem. Doing all of the other support around it, et cetera, had been a challenge. So when you start to then think about this idea that you're going to need to try to improve accessibility for hearing impaired, learning impaired, cognitively impaired, as Lee mentioned. You're talking about visually impaired. Are those numbers high enough to merit an enormous amount of priority to be spent on it? So I'd love for you to start there, Janice, to say, what is the unobvious part of this that, are we talking about 2% of the patient population that needs to worry about accessibility, or is it 90% of the population that we need to worry about accessibility? And then talk about of those where we do need to worry about accessibility and improving access, how do you actually go do it when you have 900 other things to work on?
Yeah, we all have the priority issue, don't we? I think that the important thing to remember is that when you make things accessible, it's better for everyone. So if you are going to make documents available in a portal, the way that they read and flow for everyone is better. So I think of it that way, but I really back up a little bit to think where we are going in medicine to both the provider and the payer side is more outside of the hospital, more outside of the doctor's office, more in home. So I've spoken recently to organizations that are getting ready to ship equipment to someone's home to do physical therapy in their home and be monitored over a television. And that's what they're building toward. So if we're going to go there, and I think that's where we're going, not in the next 12 months maybe, but that's where we're going, then while we build all of that capability, we have to be thinking about how do we engage everyone. And I think CMS has been extremely verbal about this, that they are looking for outcomes to be better, regardless of what environment you are putting the person in. So I think that eventually we won't be measuring some engagement things that we're measuring now. We'll be measuring things like how well did your remote monitoring work? How well did your remote equipment work? Those are going to be the different kinds of clinical outcomes that we're going to be reporting on. For now, the new CAHPS measure says member satisfaction and engagement is equal to that clinical outcome, which means you can't worry about how many people are blind or disabled, or the things that you want to categorize them as being disabled, are we disabling anyone? Because there is no room for that. If you all have worked, and I'm sure you have, everybody, on the whole measure of outcomes, sometimes it's down to, I can remember my days of going, we got to get 3 people in here. We got to get those results up, and we just need 3 people. So it comes down to every person matters. And I think as we move to consumerism more and more, we have got to make sure that there is information available to everyone. They're going to have to make decisions. They're going to have access to information. And just because a person is blind doesn't make them unable to understand or incapable of managing on their own. Many of you may know I work a lot with Lex Gillette, who's a Paralympian, done a number of interviews with him on healthcare. He's an extremely successful person. He doesn't expect to bring a third party along with him to a doctor's office visit, but he will talk about needing to stand 6 feet back and yell a social security number or a credit card number, out to the person who's sitting there to, like this, you are disabling me. And I'm not disabled, So we've got to think like that. We've got to think not only from the clinical side, are the on-off buttons capable of being read by a person who has low vision? And when we think of the numbers, to your point, let's think about elderly adults. They have vision impairments. So in this world of print, they would like the option to get those things in large print. Don't force me down a digital road. Just ask me if I could get that in a large print, and I will love you as a health plan. So there's a lot of ways to go here.
Got it. No, that's really, really good insight, is that if you're looking at prioritization, so I'm an engineer, and as we make things, we always have to prioritize them and say, okay, we're going to go after this user group first or that audience second. But I love the way that you staged this, Jan, and I'll have Lee comment on the following statement, and that is, if you took any one sliver of accessibility issues, whether it's age or visual or audio, et cetera, it might be 2%, 5%, some single digit percentage, one sliver of them. But then when you start to accumulate these, they hit 20, 30, 40, 50% of your entire population. And I think I love the way that Jan put it, which is go ahead and target the least common denominator, and then you get the most of the benefit and the bang for the buck for almost everybody else. So Lee, do you agree with that statement? And what would you tell innovators that are out in the audience looking to build the next thing from your perspective to say, guys, please concentrate on this improvement, that improvement? Where would you tell them to focus their attention based on what you've seen?
I was with you right up until the least common denominator statement. And let me say why, which is, I think what we really want to do is hyper-personalization. What we want to do is plan for all eventualities, if possible, by creating extensibility and allowing for local customization on top of a standard, platform, software platform. And so 2 things. One is, there are standards for accessibility on the web that most developers just don't adhere to. And hospitals really need to pay attention to that so that the print can get larger. The picture can be read out loud as text. The user doesn't have to rely on a graphical interface in order to interact. They have other ways that they can make progress. The graphical user interface that Apple really, capitalized, others maybe invented it arguably, but Apple really brought it to life, was a boon for many people to become intuitively comfortable with computers, but it took a big segment of the population and set them back, those who were not capable of interacting visually. So I like the idea also around, thinking about equity and inclusion. It makes us serve everyone better, because what it says is, let me just question all of my core assumptions about how you're going to consume my product and try to make it as easy, as joyful, as seamless for you as possible. So I guess I would say, if I had to, say one thing to designers and developers and innovators, it would be, there's no free lunch, right? So everything's a trade-off. That's given, but focus on an exquisite user experience. If you really focus on that and design your core principles around that, you will make a lot of progress. And what I said at the very beginning, I think it is ultimately, though, still a moral imperative. It's not a business imperative for many businesses. They can get by just fine with the 85%. For healthcare, it should be a moral imperative. If you have any question about it from a business lens, it shouldn't matter. You should be compelled to get there morally no matter what. So let's figure out how to do it in the most efficient, the most effective, the most successful way possible. And who knows, we may gain increased engagement and loyalty from other segments that we didn't anticipate reaching by this new strategy. I just want to share one anecdote with you that really exemplified this for me. Years ago, I went to the VA hospital in our area where I live in Boston. There's a couple, but I went to meet with a friend who worked there. And I got in the elevator and I had this like epiphany when I looked to push the floor and realized that the buttons are laid out in a horizontal row along the side wall of the elevator, not vertically like we're used to. And that's because many of these buildings were built after the Vietnam War. Many veterans were in wheelchairs. They couldn't reach above, 4 on the keypad. And so they're all laid out horizontally. And that's one of those moments I was like, of course, but it never occurred to me ever that the layout of the keypad was a physical limitation for some. And so that's where this focus on equity and inclusion makes you realize barriers that are affecting the majority, not just a small portion of your patient population, that you can do some amazing things for, and then everybody benefits. So I want to second what Jan said. When you think that way, you do a better job of focusing on the user experience. Everybody benefits.
So could we expand then your idea of, Section 508, which is the general regs, I think it's an OSHA reg, if I'm not mistaken, but the Section 508 regulations indicate what you should be doing to make things more accessible. Is that something, Lee, that you guys, and then I'll ask Josh to answer the same, is that something that you require in your RFPs to meet? Just like, for example, if somebody bought something at the VA, they would have to meet Section 508 compliance for it to work at the VA. Do you require that at your institution?
I suspect we do as a healthcare, a public building kind of facility. I suspect we do. I don't know the answer to that specific question, but we have a very focused effort on, as I said, diversity, equity, and inclusion. And I think what we really need to be doing is extending that beyond that concept, beyond its physical boundaries of, making sure you have a ramp at every entrance, to a more of a metaphorical approach, which is that accessibility is always one of the core design principles as you sit down to build anything.
Got it. And so, Josh, if you're familiar with Section 508 compliance, is that something that whether you include in your RFPs, et cetera? And would you recommend that to our audience members to add that to their RFPs?
Yeah, I would. We do include it in our RFP. We include it in our overall design process across the board. And to the point that Jan and Lee are making, accessibility are really key here. As I look at how we're going to continue to transform in this space, making it where a user, can personalize, the experience. We've taken a one-size-fits-all approach to this, and, everyone is different. Everyone has a different experience, and having the ability to be able to tailor and craft that. I mean, one of the things we do at SCAN, we do a lot of research, work with our members, our population, and looking at some of our survey results that were coming back, one of the challenges our members were having, I want to say it was around 14 or 15%, was just with the communication. There's a communication barrier as you're communicating over a video call versus being in person. And there's little things like having a teleprompter that is enabled through the video call, where I can personalize that. If I'm having a challenge communicating with my clinician, I can enable a teleprompter. But things like that, I would encourage us to continue to look at how do we personalize, how do we give those options to our members, our patients, to be able to personalize and really develop the best experience for them.
Yeah, and so Joshua, what I'll do here is I'll editorialize a little bit. As an engineer, when we do prioritization, it's really, really hard. So one of the things that we do have that we did not have 10 years ago or even 5 years ago was the availability of design systems with already accessibility built directly into them. So as an example, Microsoft's Fluent design system, Salesforce's Lightning design system, or Adobe's Spectrum design system. Most major corporations now have built their design systems. So you can actually go, if you're a small startup, if you're an innovator, and you're saying like, look, I don't have the personnel, I can't build all this on my own. Great, use, and they're all open source. So it's not like they're asking you to pay for these. Use the open source ones. And I think I would recommend, both Lee and Josh to look at those and say, even for startups, even for the early ones, if they use a proper design system, accessibility is not always built in because it's non-trivial to add accessibility, right? So it's not built in, but you can build on top of it without having to go from scratch. Any other things like that, Jan, that you would suggest that, is low lift? That either the Lees and the Joshes of the world can do when they're buying something, or the engineers of the world like me can do when we're building it. What kind of advice would you give us?
Yeah, so a lot of that can be done from scratch at the beginning. So if you're starting a website and you're starting a portal, if we're engaged with you, we can build it from the scratch up. A lot of engineers or programmers are not trained in accessibility. That is not touched in their training. So when they're coming out, they do not know. They're going to go in and program for you, but they don't know how to make it accessible. So we do audits on websites and portals to help, and we'll give you the exact instructions on what to do to bring those up. And we'll continue to audit so that you are meeting all the requirements of WCAG. I would also encourage you, and we're seeing more and more health plans and providers now proactively saying, hey, we're offering accessibility. Again, right out of the gate, you get a lot of really positive impression of that. So we're offering this. Here are formats you can get items printed if you're receiving print, or if you want to have this accessible PDF for your EOBs and things like that, those can come to you in this format as well. So we're seeing a lot more health plans and providers saying, yep, we want to do that proactively. We're going to let the patient, or we're going to have the member tell us, and then we're going to flag their file. And every communication that goes to them is going to be in that alternate format. So that might be Braille, it might be a large print, it might be an accessible PDF, but we will make sure that they get it in the format that they want. So we're certainly, very focused in the banking industry. Education and banking have been light years ahead of healthcare in this. We are all just getting up to speed on that. But we know the security requirements, all of that around healthcare. And I just remind everyone that 1557 of the Obamacare Affordable Care Act brought 508 right front and center to say, healthcare, this applies to you. You cannot just sort of do it the way you were. So that's why I think we're seeing a lot more focus and a lot more movement in saying inclusion means something more than we initially thought about when we said, oh, we're leaving people behind. We're much better now, as Lee says, at thinking about who all are we leaving behind.
No, that's great. And in the last few minutes that we have left, talk, Jan, a little bit about what are some of the excuses that you hear? And I know you're going to chuckle at this because you probably hear them all the time, is I can't do this accessibility because of money. I can't do this accessibility because of time, because of prioritization. Tell us, what are some of your most popular, either humorous or sad excuses that you hear? And how do you get away? And then how do you explain that to the senior leadership, et cetera, that says, look, guys, yeah, that might be an excuse, but it's not a valid one. And then when Lee and Josh jump in, I just love for them to comment on what do they hear when people say, no, we can't get to personalization, et cetera. So Jan, tell us your favorite excuses and why they shouldn't be.
The excuse I really think is that we just aren't aware. We don't think about them. And when we are brought to light that, gee, we ought to be thinking about this. And in fact, the population is much greater when, to your point, you think about who it really is, or to Lee's point, oh, it's all the people in wheelchairs, maybe, these are a much greater amount. So it's important to think about. I think the other thing is what I hear from leaders is we have no idea where to start. That seems very complicated. This is the other thing. It's very complicated. Well, it's not really all that complicated. You know, we can do an audit of a website. We can make things accessible. We can meet the same timelines that you do for everything else that you have to meet in healthcare. So that's kind of one. The other that I've heard that I find the most ridiculous is, yeah, we sort of have a kitty set aside. So if we get, you know, sued for that, or, you know, there's some risk there, we'll have the money to take care of that. It's like, oh my gosh, why don't you just spend the money, fix it now, and don't risk the PR nightmare, you know? So that's probably kind of the most ridiculous one I've ever heard. But otherwise, I think people, you know, in general, the industry is starting to go, yeah, there's a moral obligation here. And this is important, and it is kind of important on the bottom line now because of those CAP scores. So, and as we move to consumerism, all of the sharing of information, are we going to make sure that everybody gets it, or are we going to be ready to take all those phone calls going, gee, I don't know how to read what you gave me. I can't see what you gave me. I can't understand what you sent me. You know, we've got to be thinking about everybody so that they can make good decisions.
Yeah, that makes sense. And I think so from the moral imperative, I think you're going to have almost nobody disagree. There's also the imperative on the business side, because you get better reimbursements with better HCAP scores. You can stay in business if you have reasonable quality scores. So those are all good. Lee and Josh, in the last few minutes that we have left, if you can just talk a little bit about how do you actually prioritize the idea of personalization? Both of you are behind that concept. So how do you fund it? How do you prioritize it? Personalization requires an enormous amount of real world data. So is that something that you're in a disciplined way capturing, and then you can feed to the innovators or to the systems designers? Or how do you get to personalization, Lee, in your business?
Yeah, so this is what we're about to embark on in an enormous way, and I think it is CRM 3.0, right? So we've understood and plumbed the depths of personalized advertising, behavioral nudging to buy toothpaste, or handguns or alarm systems, right? You name it. We figured out how to motivate people to spend their money. Now we want to take that information and use it for good. We want to figure out how to get Jan to take her blood pressure pill morning, noon, and night. We want to make sure that Josh gets his routine screenings, his colonoscopy, make sure he takes his inhaler, whatever that is. As we move to more value-based care, again, the incentives align beautifully. In fee-for-service, it's a little more complex, but there's so much competition. And the fact that we have virtual care now has also created this open vista where anyone can compete with us now in our local market for patients, right? So it's good. It's driving us to be better. So we are really reimagining what the digital patient experience is going to be. And that's going to require partnering with vendors and platforms that can allow us to collect that information, marry that data to what we know about them from our electronic health records, maybe to claims, maybe to genetics or remote monitoring, and kind of personalized device information. So we can build really like your digital twin. We want to build a digital version of you that we can then persuade to make healthy choices and get the right site of care at the lowest cost, all the stuff that we want to do. I think it's becoming clear that to do that, we've got to catch up to the rest of the industries that have really moved into hyper-personalization, because that's what our patients are expecting now. And if they can get a trusted brand and that, you're done. Yeah. If it's trusted brand versus that, my fear is that's going to get good enough over time that if we don't figure it out, we'll be working for, the consumer engagement platform, not the other way around.
Right. So Josh, in the last few seconds that we have left, what could you guys do at SCAN to help the innovators and those that are trying to build these hyper-personalization systems? Do you share data? Are you willing to share data? How would you work with them?
Yeah, we are willing to share data. Obviously, it needs to be desensitized or what. But the one thing I would really encourage the innovators to do is reach out and talk to your users or what. And it's something that we've done well, where person-centered design, we really like to get involved and get our ideas, get our prototypes in front of our members, and get their feedback, let them be involved in that design process or what. So, don't try to, build or design something in a vacuum, engage your end user or what. And it's, been very invaluable for us.
Awesome. Well, this was fantastic as usual. Jan, thank you so much. Lee, Josh, for catching us up on where we are with respect to telemedicine, but really talking about the important parts of why access is not equal accessibility and vice versa. So just a quick note, Lee, Jan, or Josh, anything you wanted to cover that I didn't? If we've got those 2 minutes.
The only thing I would say is that I think there is a trade-off around design and with sort of agile design and the sprint, that there is a tension between, let me start rolling it out, let me start mainstreaming in the digitally literate, health literate group, while I start to do some additional design development and an iterative product development in some of those other patient groups who need more accessibility. That's probably a good approach from a design perspective, but from an equity perspective, that is sometimes looked at as not being equitable. And the fear is always, I'll never get to those subsequent agile scrums. I'll just stop with my 85% of my patient group, and it was a sort of distraction or excuse. So I think there is a little bit of tension there, and that's something that we think about a lot, is how do we work with our equity-focused colleagues to reassure them that we are intending to cover this, but at the same time, the learning that we get from other patients may also help inform us about how to make a more accessible product. So that to me is that's always a question that we struggle with.
Right. And that goes back to prioritization is if we, and having done this so many times in my own career, we almost always do exactly what you just said, Lee. We just prioritize the easiest to do, which is the non-accessible part. And then we never get to the other part, right? We just hope that we're going to do it, but we never get to it. So that's a great point, is that if we don't start prioritizing it first, and I think, unfortunately, and this mostly on the government side, has been not, quote, solved, but at least when I design for government, 508 is not an option. It's just, if you're not doing it, you're not going to get the deal. And so guess what? Work gets done. But that may be an area where Jan, Josh, and Lee, we can see if people start to add requirements on the RFP.
Yeah, I mean, what I would say there is there's the spirit of the law and there's the letter of the law. And you can meet the spirit without really innovating or driving value. You can hit the checkbox.
Yeah.
But I think what we're talking about here is going way beyond the checkbox to exquisite user experience for people, meeting them closer to where they are, as opposed to kind of meeting in the middle.
Yeah,
I love that. It really isn't about checking the box, because forever at the end of your EOB, it says, oh, if you need some alternate format, call this number. I don't know if you've ever called that number. I've called that number. You're on hold for an hour. Oh. I actually got a person finally, and she said, oh, you actually need to talk to a certain person. I was like, wow, imagine if I was blind right now after an hour wait to then be told. I would be so frustrated. I wouldn't want you as my health plan, So I think we are trying to not check the box. But to the point of iterations, I do see most organizations taking a first step in, which is, oh, we'll offer this proactively. We can get you an USB with an ePDF. It's not going to be on the website and the portal yet. We'll work to get there, because we might have to spend $100,000 to really make the website what we need it to be. So it is iterative. I do think that's where we are right now.
Got it. Fantastic. Well, this was great. Thanks. We'll wrap up now, and we'll see you at a future Health Impact event. Thank you so much.